Well, good afternoon, everyone, and a very warm welcome to King's. And for those of you that don't know me, I'm Graham Lord. I'm the Senior Vice President of Health and Life Sciences, as well as the Chief Executive of King's Health Partners. But it's a real pleasure to open this inaugural lecture in the King's Population Health Vanguard series. So an auspicious moment that you're all here to witness. So the series, Reimagining Health in a World of Complexity, has been created because we're living through what many now call a polycrisis. Overlapping challenges in demography, chronic disease, mental health, inequality, climate and technology. At King's, with our deep partnerships across the NHS and global health, we believe we have both the responsibility and the opportunity to bring together innovators, practitioners and thinkers to imagine new system-wide solutions for population health. We're therefore especially honoured to begin this series with Professor Howard Bauchner. Howard is a distinguished paediatrician and the former Editor-in-Chief of JAMA, Journal of the American Medical Association, one of the world's most influential medical journals. For decades, he's been at the forefront of shaping the evidence base for better care and better policy. This afternoon, he will speak on from quality improvement to AI, 50 years of population health innovation, lessons for the NHS, tracing the arc from the early days of quality improvement through to the transformative possibilities and risks of artificial intelligence for our health system today. We're also privileged to have as our moderator, Jim Campbell, Director of the WHO Health Workforce Department. Jim has been a tireless global leader for the health workforce, the very people who will determine whether innovations in data, technology and policy translate into real gains in population health. His perspective will help us ground tonight's conversation in the realities of frontline delivery, workforce sustainability and global equity. As we launch the Vanguard series, I hope today will do more than inform us. I hope it will challenge us. The NHS and our wider health systems simply cannot afford for us to be passive observers of change. We must lead it. So I invite all of you, clinicians, researchers, policymakers, students and partners, to listen with intent, to question boldly and to leave here committed to shaping a future where innovation, equity and population health go hand in hand. So please join me in welcoming Professor Howard Bauchner.
It's so nice to come back to London. So for 8 years, I was Editor-in-Chief of Archives of Disease and Childhood. So it's really a privilege to come back. I used to come 6 or 7 times a year. I've only been back here regularly since then. And in 2011, I moved from Archives to JAMA. I continued to be a faculty member at BU until I went to JAMA. I kept my faculty appointment, but the journals are big-time jobs, lots of people, so it was a full-time job. I was Chicago-based. And I'm back at BU, although I now spend, and this is where I met Joseph, and I want to thank him for the invitation. I spend about 3 or 4 months a year in Singapore, which has a very interesting healthcare system based both around both science as well as population health. 2 conflicts of interest to declare, although they're not relevant. MediLoop is an AI startup in California, and it's created AI agents that you can use to analyze your data. And Paper Wizard is a startup by 4 PhDs in Australia, and it's used to analyze manuscripts. And I can tell you, having used it many times, it's better than 90% of the human peer review that we get. But that's an entirely different story. So I'm going to talk about population health. And I was mentioning to Joseph, oftentimes people talk about big topics, but they don't define them, which I always find a little difficult. So I'm going to give you a definition that I'm going to use. And then a tour of the last 50 years in healthcare in general. And I'll comment periodically about how it reflects on population health more specifically. A brief discussion of each one. I'm going to spend quite a bit of time on AI because it's kind of the new kid on the block that people are hopeful will aid a revolution in healthcare. Editorial comment, predictions for the future, which is always a little tricky, and then concluding remarks. Various definitions, but I think one of the most prominent is by Kendig and Stoddard. It's from 2003. the health of outcomes of a group of individuals, including the distribution of such outcomes within the group. And we argue that the field of population health includes health outcomes, patterns of health determinants, and policies and interventions that link these two. There are some traditional measures of population health. Sometimes different variables are included, sometimes they aren't. Probably the best known are life expectancy, health life expectancy, and infant mortality as outcomes. And then how much do you have to spend to get those outcomes, okay? And that's been a great challenge around the world, and a particular challenge for the NHS in comparison to OECD countries since 2010, and I'll come back to that. And then probably one of the most famous reports, and sometimes people are just so smart and I'm so taken by them, they're prescient in what they write, and that would be Don Berwick, who is a very famous, very prominent American health policy individual. He really gave birth to the quality improvement movement over 30 years ago. He co-authored with a number of other people a document called Crossing the Quality Chasm, which is from the National Academy of Medicine, which is a small group of very prominent US physicians, in 2001. And this document claimed that there were 6 aims for a healthcare system: patient safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. And I think 30 years later, it is very clear that that has stood the test of time. Any healthcare system that can deliver on those 6 parameters is doing very well. One other comment, and these data are debated. If you look at health in general, healthcare is only responsible for 20 or 25% of someone's health. 30+% or more, closer to 70% or more, is really related to social determinants of health. And I will return to that concept later on, because I think it has to influence how a healthcare system should behave. And this is just one example. In another talk that I'm going to give, I'm going to spend a bit more time on some health outcomes as they relate to the National Health Service. But this is life expectancy and healthy life expectancy in the United Kingdom. And over here is life expectancy. And as you can see, the UK is 80.1 years. Europe is 76.3 years. The world is 71.4 years. And then this is healthy life expectancy. Females, males are on the left. Overall is on the right. And in comparison to all of Europe, you actually do quite well. But if you were to compare yourselves to the high achieving OECD countries, the 14 original countries, you're 3 or 4 years less in both areas. One caveat about these data, and all data that you will see, I don't know who's producing them and how accurate they are. And let me give you an example of why I say that. When we talk about infant mortality rate, which is absolutely considered one of the ways you measure health in a country, some countries don't count 24, 25, 26-week gestational age fetuses as live born. So their life expectancy or their infant mortality rate is going to be inflated. It will be better because they haven't counted certain groups. In addition, it's never clear in many of these statistical counts what's happening with illegal and legal immigrants. And in general, immigrants are less healthy than the traditional population in a country. So how they're counted in overall health statistics becomes incredibly important if you want to do inter-country comparisons. So quality improvement, this is a review article by Chris Castle and Don Berwick that was published in 2020 in New England Journal of Medicine. It's somewhat US focused, but I think it still stands the test of time. Quality improvement is a framework used to systematically improve processes and systems. And Demi and Donabedian, in a famous article published in 1980, really talk about structure, process, and outcome. And that had become kind of the defining model for quality improvement over 30 years. And we generally have done well on structure and process and less well on outcomes. And that would be true in population health. We're very good at structure and process, but we often don't relate it to true improvement in health outcomes. Plan, do, act, medical errors, appropriateness of care. And then a companion article or a companion manuscript was published in 1999 called To Err is Human. Don, again, was a co-author. And in it, they claimed that 90,000 Americans were dying each year from patient errors. And so that gave birth to the patient safety movement about 25 years ago. Don was once asked or told that that number was inflated, that it was only 50,000. And he said, so does that make you feel better that it's only 50,000? So patient safety has had a time in the sun, but over the last 5 or 10 years, I think not as much. And then I've already mentioned crossing the quality chasm. Okay, precision medicine. And it may arrive finally to fields outside of oncology, even to population health. It has been overwhelmingly dominated by cancer care. But it's old, so precision medicine, sometimes known as personalized medicine, is an innovative approach to tailoring disease prevention and treatment that takes into account differences in people's genes, environments, and lifestyle. And it emerges in 1907. It's more than 100 years old. Sometimes you think you've created something new, like the new kid on the block in clinical research is trial emulation, when you take observational data and you try to analyze it so it looks like a clinical trial. It's actually been around for about 40 years, but no one called it trial emulation. It's not so new. But we learned that in the early part of last century that people have different blood types. And so we began to realize you have to be a little more specific when you transfuse. And then, of course, 1953, Watson and Crick described the double helix. And obviously, people recognize that Dr. Watson died last week. I think he was 97 or 98. An extraordinary career until the last 20 years. The last 20 years were a very difficult time for some of his views. I would also say the manuscript that was published in 1954 in the journal Nature is 1,006 words long, 1,006 words long. So when people write 5,000-word manuscripts, the manuscript that is the birth of modern medicine is 1,000 words long, okay? And they concluded that we may have found a possible exploratory mechanism for the basis of human life. So they hedged their bets, okay? So I would argue when you write a manuscript, hedge your bets in the conclusion. Antibiotic sensitivity testing in the 1950s, best epitomized by cancer care, and there are some examples. 2001 is the publication of the entire Human Genome Project. And now I think people are trying to move on from large cohort studies to something called N-of-1 studies. But last week, I read a paper. Sometimes I pick up a journal, I read a paper, I go, that's an oh wow paper. And it was in New England Journal of Medicine, and I was just mentioning it to some people. They looked at 3 diseases: inflammatory bowel disease, I think multiple sclerosis, and atopic dermatitis. And they had data from the UK Biobank, so they had their entire genome. And what they found was that depending on which condition, between 3 and 5% of the people didn't have that diagnosis, but they had a genetic disorder, and they had been misdiagnosed for all those years. And so to me, it's the first inkling that genome sequencing may be of value outside of cancer. And I think we'll be hearing more about that as we go forward in medicine. What's interesting about it was that the 3 to 5% of people who had genetic disorders were also poor responders to treatment. And so that may give a clue to who should undergo genetic testing. Okay, so as you get older, you'll realize trends come and go. So I once got a paper saying at JAMA from University of Chicago docs that it would be really good if primary care doctors visited their patient in the hospital so that there'd be continuity of care when they left the hospital, okay? So in the United States, primary care doctors don't visit their patient we now have turned it all over to hospitalists. So they wrote like this was a new idea, like a new concept, like their primary care doc should actually see patients because they had grown up in an era of hospital medicine, hospitalists. So I had to write back to them, well, if you were a little older, you would have realized that's what used to happen before we introduced the new system of hospitalist care. Well, the learning health system was really a hot topic for like 10 or 15 years. And then it kind of disappeared. And I'll tell you why I think it disappeared and where it failed. Learning health system, science, informatics, incentives, and culture are aligned for continuous improvement and innovation. Institute of Medicine grows out of crossing the quality chasm. And here is where I think the great mistake was. And I think this is a challenge in the realm of population health. You can learn a great deal from all the patients that you take care of at King's. You can learn a great deal about population health from all the people that live in this area. But you will learn a lot more from other places than you will from yourself. And that has been the failure of the learning health system, to have this notion that you could learn enough from yourself to generalize to your broader population. Most of the great research is not done at King's, it's not done at Harvard, it's not done at Oxford. It's done at places around the world. And so the great failure for population health and learning health systems is not to learn from others and then to adopt it locally. And I think that's been a great failure. So as an example, Deb Schrag 2 years ago published this article in New England Journal of Medicine, which said if you had rectal carcinoma, you no longer had to undergo radiation treatment. That in a non-inferiority trial, the outcomes were identical. So if you truly had a learning health system, you would have ingested that paper and you would decide if you agree with it and has to be interpreted locally. And if you do, then patients should stop getting radiation therapy. That's a learning health system. But I think a learning health system was misconstrued, that you could learn so much by yourself or by your own data that you didn't have to pay attention to other people or other groups. These are many other themes that I don't have time to touch on at length. Evidence-based medicine, which was not born in the United States. The seminal series occurs or is printed in JAMA in 1986, but the evidence-based medicine started in Oxford and at McMaster. So in the UK and the United States, although because it was in JAMA, people always think that evidence-based medicine started in the United States. Clearly, particularly around COVID, and the notion of inequality and equity in healthcare has been this great interest in social determinants of health. Poverty, education, housing, climate. And so that has given birth to this movement of screening patients for social determinants of health. And briefly, I would tell you there's no data to support that. That doesn't mean you shouldn't do it, but at the moment, it's not yet certain if physicians, clinicians, or practices screen for social determinants of health if it improves patient outcomes. Now, as people always say, the absence of evidence doesn't mean you shouldn't do it, but I would be very restrained about how aggressively you should do it across the system. Implementation science, I always say drugs and devices scale, biobehavioral interventions do not scale. I think AI may change that, but in general, biobehavioral interventions don't scale because they're expensive and they're very local. So I know that patient navigators work. I know that home visiting works, but it never scales as soon as the trial is over, whereas drugs and devices definitely scale. Reproducibility and replicability, misinformation and disinformation. I've spent the last 6 months writing quite a bit about research integrity, which has to do with research misconduct. There's a lot of evidence of data dredging, a lot of evidence that if you give me a data set, I will find whatever outcome you'd like, okay? Just give me enough data and I'll get the outcome you want. Open science, which is really open access data sharing and open peer review. It has not been as successful as people hoped. People thought it would democratize science. In fact, it's led to predatory publications. And so I think we're not quite sure what the benefits of open access has been. Obviously, a great deal of congratulations belongs to Richard Horton at Lancet. I think he, more than any single individual, galvanized the world to think about global health. And I think Richard deserves an enormous amount of credit. Because of the series of under 5 deaths in Lancet, I think that woke the world, the eyes of the world about the importance of global health. And they were published almost 25 or 30 years ago. Real world evidence, trial emulation, health equity, a huge issue in the United States. And I remember my friends from Canada once said, well, we don't have any health equity problems. And I said, well, have you looked at your data? And they said, no. I said, well, when you look at your data, then you can tell me if you have problems with health equity. So even in the NHS, which is an extraordinary experiment and system, you have health equity problems, generally based upon class and race. Scientific advances in immunology and genetics, drug discovery, device innovation, vaccine development, all extraordinary. There's been some comments that innovation has slowed in the United States and around the world. To me, that's not that evident. I mean, it's extraordinary in my lifetime to think you could actually cure a child with sickle cell disease. So my practice, we took care of many children with sickle cell disease. It's just extraordinary to think that in my lifetime, those children will be cured. Okay, I'm going to turn now to artificial intelligence. Sorry, I just want to make sure I'm on time. Great. Okay, so some definitions, because it's complicated. A branch of computer science that focuses on creating machines, computer programs, or software, large language models, an AI model trained on large amounts of data that can be adapted, neural networks, a computer system made up of interconnected artificial neurons, machine learning, where computers analyze data to perform tasks without being specifically programmed to do so, generative AI, AI models that analyze training data and then generate new data, and a new kid on the block, AI agents. Does the AI make a decision and does the AI take action? So you can interact with data. The AI agent will prompt you to do more and more or ask different questions. At the moment, AI agents can now produce scientifically robust manuscripts. If you ask the correct question and you give them the appropriate data, they will produce a manuscript for you. Just one comment about some of these definitions. You'll see on the next slide one of the seminal papers in artificial intelligence. It was written by Jeff Hinton for JAMA about 10 years ago. Jeff won the Nobel Prize 2 years ago. I told the story earlier today on the recommendation of one of my editorial board members, David Naylor, who was at University of Toronto, and they were close friends. They said, why don't you have Dr. Hinton write a paper for you? So I emailed him, and he was famous then, but he's since become much more famous. He said, sure. So he writes the first draft. It's 1,500 words. I could understand none of it. I didn't know what language it was written in. It was English, but it wasn't very understandable. I sent it back to him. I said, Jeff, you know, I'm just a doc. It's really hard. This is like his computer language. That's really hard. Rewrites it, sends it in. Now I can understand 50% of it. And I've shared it with other people. And so I said, I send it back to him. Apparently, Dr. Hinton calls David Naylor, his friend, and said, I'm frustrated. This is the best I can do. He sends it back to me and said, take it or leave it. This is the best I could do. So I think for all of us who are struggling with what AI really is, you're not alone. It's kind of a black box. We have a sense of what it's doing, but I think it's pretty hard for many of us. And then the two pictures on the right, the top is by Zach Cohane. And Zach published this in 2014, so this is a long time ago. And it was the first paper that we had that talked about, kind of hinted about what the role of AI could be in medicine. And the way he depicted it is he talked about all of the data that go into someone's life. And some of it is structured, some of it is unstructured. And this picture has been downloaded about 500,000 times from JAMA because it gives people a sense of what they think the power of AI could do with different elements of data. We heard about the Embrace project earlier today, and they had a very similar slide about how do you get data from a smartwatch or electronic health record or discharge summaries and collect that data, both structured and unstructured, to give you a view of an individual. And then JAMA published this last year, 3 epics of artificial intelligence, AI 1.0, AI 2.0, and then AI 3.0. And for people who want a primer on AI, these are probably worth reading. Okay, so I would say the paper on the upper right, published in 2016, is the seminal paper about the power of AI in medicine. It came to us from Google Health. And what it said is that we can create a machine that takes a picture of your eye grounds, and we can tell you whether or not you have diabetic retinopathy. Okay. It has subsequently been cited now, I looked this morning, 4,500 times. And it's the first paper. There's a paper earlier that year, but in a less well-known journal, that really begins to say AI has a future in healthcare. Then along with that paper is Jeff's paper a little later in that year. And then I've already mentioned how we think about big data. That was by Zach and Andy Bean. This paper from Lancet and New England Journal of Medicine, the one from NEJM, Ambient AI Scribes to Alleviate the Burden of Clinical Documentation. That paper is important because of the so-called concern about burnout among physicians. And so that's the administrative roles that many physicians play. In the US, it also includes approving certain drugs and treatments called prior approval. I do think AI is clearly going to help with some of the administrative responsibilities that physicians have, or clinicians in general. For example, summarizing discharge summaries, summarizing progress notes. I went to see my physician. She took no notes. And I said, well, what's going to be in the medical record? She goes, well, I have an AI scribe who's going to take our conversation, and that will be the note. Now, I would only say one concern about that. There are concerns that AI hallucinates, okay, or makes up things. So an example would be someone comes in with their child and says that they got hurt, that he was playing soccer. And then the AI scribe will say, a soccer player came in, an adult came in who was a soccer player. So they can hallucinate. The problem I have with it as a scribe is whether or not physicians will stop rereading what the scribe has said and just post it. And so that could be a potential problem. Clinical care. AI can read path reports. AI can read echoes. AI can read EKGs. Any reading task that requires interpretation, AI can do as well, if not better, than human beings. But that doesn't mean it's going to improve patient outcomes. And at the moment, there's virtually no article amongst the thousands that have been reported about the value of AI that have reported an improvement in patient outcomes. So it can detect more breast cancer. It can detect more polyps that should be biopsied. But from detection, from screening to case finding, detection to treatment is a long road filled with a lot of potholes. And so where the AI movement is lacking at the moment is to know whether or not it can truly improve patient outcomes. It will revolutionize scientific publication. It will revolutionize scientific publication. I believe that every manuscript submitted to a journal within the next 5 years will undergo initial review by an AI algorithm. And why do I say that? Because last year there were 3 million manuscripts published. Another 2 million were rejected. So theoretically, you needed to do about 10 million peer reviews. And I can tell you the capacity of human beings to keep up with the amount of science that's being produced no longer exists. Plus, peer review is inefficient, ineffective, and biased. So for the journal editors who don't think they'll be using AI, they are going to get left behind. And I can tell you, having used all of the systems, that AI peer review is excellent. It's not perfect, but it's going to be married to human peer review in the coming years. Will it improve population health? That is a great question. I have written previously that I think it will not. And why don't I tell you why I don't think it will, and if it does, where I think it will. There's no unknown about how to improve population health. You want to minimize poverty, you want to give people housing, and you want to give people good jobs. The data are overwhelming. Don't be poor, have a good job, and have housing. Medicine doesn't own that. Government owns that. And when medicine tries to fix those things, we're not very good at it, okay? And so the real question is, do you live in a society that is willing to fix those things? But medicine does own some things, and we don't do them very well. And the question is, can AI help with that? So what don't we do very well? Well, we've failed for 30 years with the treatment of obesity, okay? We failed for primary prevention, we failed with secondary treatment. But the drug companies solved that problem for us. It's extraordinary. The GLP-1 inhibitors, I've never seen a class of drug that's so successful in virtually every disease that it's been used. So obesity. The second is hypertension. The data that I've accumulated over the last 5 years is overwhelming. A blood pressure of 110 is better than 120, 120 is better than 130, and 130 is better than 140. But half the patients in the United States with hypertension are either under-recognized or undertreated. And the question is, will AI help with the treatment of hypertension? I don't think so. And the third is cholesterol. And again, I don't know if AI will help. Now, where may AI play a role? In the great unknown of mental health, believe it or not. And I will just provide a personal vignette. So my two nieces, who I won't give you their names, were at our house, and my wife's a therapist, and we got into the discussion, if they needed mental health, where would they go? And they'd go, well, we'd never see a therapist, but we'd call up ChatGPT. She was stunned. They're still our nieces. We still love them. We just love them a little less. But there's a whole group of people out there who are going to engage with ChatGPT, not only around traditional health outcomes, but I think around mental health. And we know as a discipline, as a field, mental health has not been well delivered across large segments of the population. Will ChatGPT or other large language models be good at it? That question is unknown at the moment. The other area in which AI may help, but we need more data. I already told you that biobehavioral interventions don't scale very well because they're just too expensive. So, I can tell you, I told you that, patient navigators work. They'll improve adherence in coming to a clinic, or home visiting works, or cognitive behavioral therapy embedded in a randomized clinical trial works for post-traumatic stress disorder. But delivering that on large scales has been very, very difficult. If AI is successful, it will scale, and it shouldn't be that expensive. So the one thing I would say, one of the great potential transformations is if we can show that AI can improve how people think about diet or how they think about exercising. If there's an interaction that an AI tool can have with an individual, whether or not it can improve those outcomes, AI will scale. Now, the issue is, do you want to create AI integrated with healthcare or that it's layered outside of healthcare? And there's tension about that. So when I'm in Singapore, they have two different ongoing trials. One is integrated with their general practitioners, but one is very separate from their general practitioners. And so you have an AI model delivering recommendations that's unintegrated with healthcare. It gathers data from the healthcare system, but it's not really integrated back to the healthcare system. And I think that's going to be a challenge going forward. These are just some themes that will emerge, and then I have one final slide. As I've already said, CRISPR-Cas gene editing for sickle cell disease and beta thalassemia, I never imagined I'd see it in my lifetime. The third bullet, whole genome sequencing for newborns. I predict in 10 years, in societies that accept it, you will sequence a newborn, you will sequence the entire genome of every newborn in this country. Data are emerging that can be helpful. There's confidentiality issues, who owns the data, the ethics of whole genome sequencing. For example, you sequence a newborn, they have long QT syndrome, it doesn't manifest until they're 25. How do you deal with that information? But I could imagine that some societies or small areas in countries will do whole genome sequencing on all newborns in the coming years. The epidemic has taken its toll around the world. The US finally has rates that may have flattened. This is a world report, a report from the WHO. They go through 190 countries. As you can imagine, the US, UK do very, very poorly. This is probably one of the newest and greatest concerns. The planet is aging, so people who are older thought there'd be a time when we wouldn't be able to feed the world's population, that we'd run out of usable space and water. Those are still challenges. But the world's population is now estimated to peak at about 2060. And so what's really emerged is that the number of people in most countries, the US and the UK, that are older than 65 with multiple morbidities is increasing dramatically every year. And I like old people because I'm one of those, okay? And I want to live a long time, but the question is, how long do I want to live and what's the cost to society? So healthy longevity has really become a central question for every country. Obviously, just living longer comes at great expense. And so that becomes a real challenge for the NHS and any healthcare system. And that, I would say, needs to be one of the focuses of population health. How do you think about healthy life expectancy and healthy longevity? And someone's introduced a new term called flourishing, which is really a companion of healthy longevity, and it's on the upper right. I was optimistic about climate change and health in the sense this Lancet Commission talked about both the relationship between climate change and health, and then more importantly, that healthcare consumption or the carbon footprint of healthcare could finally be tamed, okay? And actually, the UK was doing better than almost any country in the world about taming the amount of energy that your healthcare system uses. That all ended with the introduction of AI, okay? We are consuming energy at an enormous rate. Academic medical centers, hospitals, research institutes. And if you don't believe me, then try to understand why Google, Microsoft, and Amazon are all building nuclear reactors, okay? They do not believe that there's electric grid in the United States in the future will be able to provide the needs that they have for AI. So I'm less optimistic about sustainable healthcare than I was a few years ago. And this is a piece I wrote with John Ioannidis, who's a very, very prominent epidemiologist, somewhat provocative. He's Greek, but he's at Stanford now, called The Subjective Interpretation of Medical Evidence. It's a huge problem. And I will give you one example. In my lifetime, we've only done really well with two global changes in behavior, okay? I haven't done very well around nutrition. But we really did well around smoking. Okay, smoking rates around the world have plummeted. Like my kids have no idea that you used to be able to smoke on an airplane. Not only could you smoke on an airplane, you could be sitting here and then there was a curtain and these people are smoking and these people aren't smoking. I remember when they were teenagers, we took them to Paris and someone was smoking in the restaurant and they asked us if we could leave. Like they had no notion that smoking was so prevalent, okay? That's really a good behavior change at the global level. But there's another global change in the last 5 years, which isn't so good. So in 2018 or 2019, international surveys suggested that 1% to 2% of adults were vaccine hesitant. Because of misinformation, disinformation, and the COVID mRNA vaccine wars, that is now 20%. Okay. And I believe it's based upon what John and I call the subjective interpretation of medical evidence. So there are just two major reports about drinking. One says I can drink small amounts all week and it doesn't affect my mortality. There's another major report that came out that told me I shouldn't drink. So I didn't read the second report, I read the first report. And I sent the first report to my wife, but I didn't send her the second report. So how is it that these two august bodies looking at the same data have come up with very, very different recommendations? Screening for breast cancer, screening for prostate cancer, screening for colorectal carcinoma, the political wars about gender-affirming care are all involved in the subjective interpretation of medical evidence. And the question is, how do we move past that? And it's not entirely clear to me. AI will have little impact on population health, and I hope I'm wrong, okay? It was so nice, I don't think Joseph's gonna invite me back after that statement. But time will tell, okay? As I said, I do think there's glimmers of hope around scalability. So if you can prove it's effective, then you're over one of the great hurdles, which is implementation science. Poverty, education, and housing, so-called social determinants of health, healthcare, obesity, hypertension, elevated cholesterol, and I would add, obviously, mental health. Drugs and devices scale, biobehavioral interventions do not. Public health and medicine can inform population health. That's a critical role of everyone in this room, but government must drive population health. You don't have the capacity to drive population health at the national level from a single institution. You have to figure out how to work with policymakers in government over a number of limited issues that you think could be transformative around population health. And the question is, do you want the current Minister of Health to work on 5 things, 10 things, or 2 things? And these are really important strategic decisions. And I honestly don't know the right answer. There's a very famous trial that was done in your GP practices. It was reported, I think, in NEJM 4 or 5 years ago, where they began to pay the GPs to do certain procedures. And they did those procedures, but they stopped doing other procedures. And so you have to be careful about about unintended consequences. Thank you.
Excellent. Thank you very much, Howard. This one hopefully now is switched. Yes, all good from the tech. 45 minutes there, masterclass, coming back to what Graham was saying around this Vanguard series. So I'm Jim Campbell. I work at the World Health Organization. I've been there for almost a decade now, and I'm dependent on people like Howard and yourselves to produce the evidence, to publish the evidence, to then 197 countries around the world, consolidate that into, well, what do we know? What are the issues? And this Vanguard series, which Professor Josip Saar and the team have put together, is really, as Graham was saying, challenge of, asking questions about that data, asking questions about who holds the power to publish, to create knowledge, to publish, to disseminate it. How much trust can we have in some of this data to base our policy and practice activities on? And Graham was saying we can't be passive observers to this process. We have to challenge, we have to get engaged. And yet there's some of the historical lessons of what's happening now being revolutionized. 5 million plus manuscripts a year circulating. What is the truth? What can we believe? What can we take further forward to improve public health services, population health outcomes? So Howard, I mean, fantastic in terms of things. So we've got about 15 minutes before we're enticing you to stay with us because we're offering you drinks afterwards. You have a budget for refreshments, something the WHO no longer has. So we're offering you drinks afterwards, about 15 minutes. We want to try and engage you in this curiosity, in this understanding, and take some, any remarks, any observations, any particular points on anything Howard said. If not, I've got a list of questions for him. Gentleman here.
Yeah, thank you so much. Incredible insight.
If you can just introduce yourself quickly.
So I'm Michael. I'm an academic pediatrician. And my question is, I completely agree with you. I need to be of AI, particularly in children, particularly areas of health. However, I worry around the risks of the kids now. There's some evidence that social media use is reducing, but they're going to chatbots and AIs. How, as we as academic pediatricians, what do we need to do in terms of the science and the work to show potential harms, to mitigate against them, to influence policy?
Can we take a couple? Can we take a couple of questions?
Sure.
Yeah. To get the thoughts going. Gentleman there.
Hi, I'm Peter Ward. I'm a real estate guy, jointly appointed by the university and going to Hospital. You said I completely understand AI won't directly affect population health, but the NHS is under massive pressure in relation to productivity right now, and particularly not having recovered from COVID and to pre-COVID levels of productivity for whatever reason that might be. Do you think there's an indirect correlation potentially between our efforts to improve productivity and the outcome on population health?
Got one more? Madam.
First question. So I'm a pediatrician. My children are older. I told this story earlier. So I was at a meeting in Singapore, and there's a group in Singapore, the Gusto group, that's done a lot of research. They have a longitudinal cohort study. Kids are now 17 or 18. They've done a lot about social media. JAMA Pediatrics, Dimitri Kradakis, has published quite a bit about the potential impact on social media and mental health of children. I don't sadly have a very good answer because I can't change how the large language model companies are behaving. But I would say one thing. When I was in the Singapore meeting, when they were talking about trying to make recommendations at the national level in Singapore about when children could have devices and when they could go on and how they could limit it, almost everyone in the meeting was on their own device. So I don't know what, if you have children, your children are like, but my children learn mostly from what I did, okay? I don't think when I go out to dinner with friends, I try to put my phone away, but I can look at other people in mealtime, and all four of them are on their phone. I felt like going, why'd you go out for dinner? You should have just gone somewhere else and been on your phone. So I do worry a little that we're not very good at modeling, okay? And that includes me. So I worry that we haven't served a very good example for children. Ultimately, countries are going to decide how they're going to deal with some of these companies and request laws around safeguards. How effective they'll be is unclear. I heard this really funny story the other day, and it was that, in American schools now, most of the schools finally said to to students, you have to deposit your phone when you come to the school. You're not allowed to have it anymore. And it goes in a lockbox or a lock something. And there hasn't been much protest, except now a third of the kids carry 2 phones. They get their parents' old phone so that they can still go on the phone. Now, I think the solution is much simpler, which is a teacher should say, if I see the phone, I own the phone, and your parents have to come and get it. It will end right away. Because the last thing parents want to do is to have to go to school 3 times a week to get their kids' phones. But I can't give you better ideas than what I suggested. The effects could be indirect. Okay, so presumably, as I said, I think AI will really help with administrative tasks. So if you can make it easier for specialists or your GPs and they feel more comfortable in what they're doing, their productivity could increase. But simply asking them in the same system to see more patients is not going to be a very effective approach. Now, I'll say in a later talk, since 2010, the NHS has grown up to 2 years ago at about 1.5% per year, which is about 50% less than the average across the OECD, which grew at about 3 or 3.5%. Now, it may not seem like a lot, but it's hundreds of billions of dollars from 2010 to 2022 or 2023. So you're finally seeing an increase in 2023 and 2024. So last year, I've read that you're somewhere around 11%. You people here probably know the percent more. But you're going to have to go to 12, 13, or 14% if you want to catch up for that 15-year period. And obviously, the money needs to be well spent. And you have to stop reorganizing the NHS. You can't reorganize the NIH every other year. It's not a very effective model. Okay. And then the third question was? And
energy. The energy.
Oh, the energy. Yeah. In a talk, when Joseph's group on Embrace was presenting, AI people know that they're using a lot of energy, okay? But my understanding is from a technical standpoint, people are already working on models that will reduce the overall use of energy so that it doesn't consume quite as much as it does now. But I would say, in a different vein around the planet's carbon footprint, President Trump aside, that I believe that over the next decade, we'll see technical solutions. And we need to give our Scandinavian colleagues a lot of credit. They're working on withdrawing carbon from what already exists. And apparently there are some already successful early experiments about trying to remove carbon. So it will take a renewed interest in solar. I know this may not be a very popular comment here, nuclear, removing carbon. What we can't do is we can't tell a country like Brazil, you can't chop down your forests. That's for Brazil to decide, okay? It's not for the United States to decide. The United States chopped down their entire forest, okay? We can't tell Scotland, you gotta leave all the bogs alone, okay? That's for Scotland to decide, okay? And so I think the global north has to be very careful about how they talk about the global south or talk to the global south.
Very good, thank you. Two more, gentlemen there.
So I'm Dan, I'm a medical registrar and also a population health data scientist. I just wondered, do you think that in terms of your position on there being no role for AI in population health, like I'm presumably optimistic, so I'm working on this stuff, but like building models to risk stratify patients for interventions, like as far as the role of medicine goes, is there not a role for AI in trying to decide who we're going to treat or pick out patients who would benefit more from treatment?
Okay, so the question is, and this, I touched on it, but I didn't I didn't belabor the point. It's called N of 1 trials, number needed to N of 1 trials. The most effective broad class of drugs before the GLP-1s are statins. Do you know what the number needed to treat is for a statin trial? It's 20. 19 people don't benefit. 1 in 20 people benefit, okay? Even for the GLPs, if you look at just a 5% reduction in body weight, not 10% or 20%, the number needed to treat is 5. So that means 4 people aren't benefiting. So why give the drug to 5 people so only 1 benefits? The question is, can AI help us with that? At the moment, it's unclear, but that's what precision genetics, genomics, people had hoped would populate other disciplines other than cancer. So I think if AI has a role, it could be in trying to successfully reduce the number needed to treat for successful drugs and devices. Now, here's the challenge. That's not what drug companies want. The drug companies want the largest population possible because of the financial interests that they have. So they'd rather be forced or to indicate you have to treat 5 people to benefit 1 versus only treating 2 to benefit 1. So that work is going to have to come from academic units. So you're right, it could have a role there. But like from Missouri, you have to show me first.
Great. Yeah, that has fantastic. I think very evocative. Challenge back to us. So just a brief challenge back to one of your early slides. One of the greatest successes of precision medicine is organ transplantation, which is curative and actually never had a commercial value. So tissue type is the ultimate precision medicine, which it's not just oncology. So I say that as a transplant physician. So that's
Okay.
self-promotes my discipline. That's not the question. The question is, we've not touched on education, and obviously, given that Jim's here, so
Yes.
so we've had multiple discussions over the last 5 or 6 years,
Okay.
particularly in the US, because we use medicine and healthcare interchangeably, and I think they mean different things, particularly if you talk about ownership and incentives.
Yeah.
So do we need a Flexner report for 2025?
Yeah. So if people didn't hear the question, it was around how do we educate health professionals going forward in a world that's dramatically changing, particularly focused around AI. You could focus on other issues, but I think AI is the one that people are most interested in. And he alluded to something called the Flexner Report, which was produced on behalf of the AMA in 1915 or 1916. And it led to the closure of 6,000 medical schools in the United States and the adoption of the German model for education throughout the United States. It gave birth to kind of Johns Hopkins as a modern medical system. It's very famous. It also was very discriminatory around historically black medical schools, but let's put that aside. So the question is, do we need a new Flexner report? I don't know, in the sense that we knew that health education in the 1900s needed to change because it wasn't very science oriented. And so the AMA had singular power then to be able to do that. At the moment, the AMA would never have that amount of power. It could come out, every country usually has a professional body that's responsible for medical education. So I'm talking about physicians. I know the US and the UK does. So the question is whether or not they would report or they would produce such a report. Interestingly enough, New England Journal just had a long review article about AI and medical competencies. And so I think people are now beginning to talk and write more about it. One of the things that we discussed, one of the interesting side effects of AI is de-learning. And so now there's elements that not only do people not read what AI produced, they just put it in the medical record. Once they get dependent on AI, they may stop being skilled at doing certain things. And so the question is as you think about the workforce, how do you educate them? But my last comment is why it's such a challenge. There's about 1.2 million physicians in the United States. We graduate 40,000 a year, okay? How many years would it take to have an AI-educated workforce that would represent even 25% of the total workforce? So when you talk about education, you can't talk just about medical students and residents. You have to talk about the existing workforce. And most of physicians are, kind of mixed about how much they want to learn. They're busy, they work hard. So any professional group addressing them should talk about more than medical students, but they have to recognize for busy clinicians, it's going to be a challenge. I'll stop there.
Just to add to that on the thing, we did have the 100-year anniversary report, which was the Commission on Transformative Medical Education, led by Julio Frank and others with Richard Horton at the Lancet, and they published. But that date was, you mentioned it earlier, Howard, the go-to paper that you were saying around the potential of AI, right. 2016, was it? Yeah. So you've got the last major review of medical education worldwide at the same time as AI starts to come onto the scene and everything else. So there's huge discussion. The work that Josip has published on digital competencies now in medical education, the expansion of that into digital health literacy and a future AI-prepared, AI-ready, practice-ready workforce is the key discussion, I think. And watch this space. We may have an announcement for you soon on a new international commission to look at those questions coming through. We're at time, but I just got one final question for you, Howard, because you were talking around bias in the system, our current system, and you, of all people, know this really, really well from your prior career in terms of getting that through, and the potential of AI maybe to get rid of some of that bias accordingly. But if our evidence has got this bias in it, and we're trying to improve population health, and you challenge that maybe AI won't yet do patient outcomes, population health, where would you say that this King's Health Partnership, where would you say that the King's Health Partnership and some of the faculty and staff should be looking to add value?
Right. So I guess I'll add two specific answers. So I think when people say AI could be biased or it could hallucinate, people are asking the wrong question. The correct question is it more or less biased than human beings? So if you and I write a discharge summary, I can tell you they don't look alike, okay? And if you're a specialist and you're a generalist, they don't look alike. So I think when people are worried that AI could be biased or hallucinate, it's true, but physicians are biased and they hallucinate, okay? Actually, I suspect they hallucinate and are more biased than AI, but that's a testable hypothesis. So I think people sometimes are asking the wrong question around certain issues in AI. The second point you make is much more complicated. As Joseph mentioned to me earlier, a poor data in usually means poor data out. And so that's particularly relevant to AI models that are going to begin to go through an electronic health record, for example, and say the patient is diagnosed with hypertension, okay? And then that carries forward. We all see that in the paper and clip, something carries forward from progress note to discharge summary. Where I'm more optimistic is that AI could be taught if a patient has a diagnosis of hypertension, what justified that diagnosis, okay? Is there a blood pressure reading? Is there more than one blood pressure reading? Is the patient on hypertensive drugs? So I think there may be a way in which AI can be taught to look at the data to then try to validate what it is then telling people. But it is a huge problem, and I'm not sure we have an answer for it yet.
So which is assurance then that Josip and his team still have a future looking at some of these questions and this translation of knowledge. Howard, well, that's it. We're at time. A huge round of applause, please, for Howard.